You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for April 22nd, 2022. This week, I wanted to do a correction and some rebuttals on the VT ablation story from last week, European Heart Rhythm Association review, including new ways to ablate atrial myocardium, and also new ways to pace the ventricle. So let's first revisit the VT comments I made last week. If you haven't listened, you might do that first. I misspoke slightly in my review of the Partita study of early VT ablation versus standard care after an ICD shock. Partita found that VT ablation reduced the primary endpoint of death or heart failure-related hospitalization. Well, I criticized this study on many fronts, and one was that VT ablation improved overall mortality, but did not really reduce VT. I said this, quote, cardiac death, recurrent VT, VT with anti-tachycardia pacing, or VT with ICD shocks did not differ in the two groups. That last phrase, VT with ICD shocks, was actually lower in the ablation arm. It was 2 versus 10 with a p-value of 0.039. Thanks to Dr. Dimitris Sakaris for listening so carefully. I'm sorry for the mistake. However, my criticisms of this still stand. Recurrent VT of any type, of which there were more events, did not differ between the ablation and standard of care arm. And again, the primary endpoint of Partita, which had 23 patients in the ablation arm and 24 patients getting standard of care, had a positive endpoint driven by non-cardiac deaths, which could not have been affected by either arm. Okay, I also received an extremely kind email from one of the Survive VT investigators. He disagreed with many of my criticisms of Survive VT, which is the second trial I discussed last week. This trial was conducted in Spain, and it compared early VT ablation with substrate type of ablation to antiarrhythmic drugs in patients with ischemic cardiomyopathy who had had an ICD shock or sustained VT. Survive VT had 144 patients, so it was a bigger trial, and a primary endpoint of many things: CV death, ICD shock, heart failure hospitalizations, or this category, severe treatment-related complications. I want to go over some of my colleagues' most important responses to my criticisms. Now, first, he took issue with my citation of a 14% complication rate. He noted that in their supplement, they broke down complications into major and minor, and there were 8 major complications in 7 patients, which is actually 10%. And 2 of those were slow VTs, which if you excluded would make an 8% complication rate. He also points out correctly that antiarrhythmic drugs also have complications. So my response to that is that, okay, yes, 8 to 10% is still a high complication rate, especially considering that the trial is conducted in expert centers on carefully selected patients. Okay, second point of contention, my colleague took issue with my comments that VT ablation should reduce the primary endpoint via reduction of VT. Again, in Survive, rates of ICD shocks, cardiovascular deaths, total deaths, and any VT were similar in the ablation versus antiarrhythmic drug arm. His disagreement was this, quote, you made it sound, me, Mandrola, made it sound like VT ablation is a curative procedure, and I don't think that is the case. VT ablation is an adjunct therapy to an ICD aimed at reducing VT recurrent events. And the more you reduce VT, the better. but I think it is unrealistic to believe that VTs can be eliminated. I would respond by that saying that's fair, but keep in mind these were patients who had had only one ICD therapy or one episode of sustained VT. Okay, he also took issue with my critique of calling sinus bradycardia and hypothyroidism severe complications. And if you do that, you made the antiarrhythmic arm look worse. His rebuttal to that was that the hypothyroidism case in their trial was symptomatic and it led to discontinuation of amiodarone. And both cases of sinus bradycardia and dyspnea were symptomatic. And so these are fair rebuttals, but still, none of these types of complications are akin to a stroke or pericardial tamponade from an ablation procedure. A fourth disagreement centered on my comments that slow VTs in the antiarrhythmic drug arm are not as severe complications because part of the efficacy of antiarrhythmic drugs is to slow VT, and if it's recurrent, it can be ablated. Now, my gracious colleague from Spain wrote, quote, antiarrhythmic drugs slow conduction velocity, but the reason we use them is not to slow VTs, it is to prevent them, right? Suffering a slow VT led these patients to the hospital because they were symptomatic, many of them with VT lasting hours and requiring cardioversion. He noted that 5 out of the 15 patients had incessant VT, defined as VT that recurs promptly despite repeated interventions over several hours, and this is a serious condition that may require urgent VT ablation. And that is also a fair criticism. Now, there were some other minor points of disagreements, but I want to say how much I love these comments and interactions. I learned so much from them, and I hope by discussing them here on the podcast, you can too. I also want to reiterate strongly that my critical appraisal of a study or trial is never meant to be personal. I've gotten involved in trials recently, and I now understand firsthand how damn hard they are to do. I mean, this week, I heard results of an NIH trial that I was part of, and as proponents of the thing that we were studying, we had hoped for stronger results. So I get it. My aim here is never to diminish the work of generating evidence. My aim is to help clinicians appraise the evidence in a neutral way and be able to better translate it at the bedside. And it is totally true that I have biases. I have lived through many periods of irrational exuberance in cardiology, especially EP. In large part, this happened because we were too easily bamboozled. We were unable to critically appraise the evidence for ourselves. These experiences have led me to become medically conservative, so part of my aim here is to provide a cautious approach to new therapies. Okay, next topic. I've spent a couple weeks reviewing the recent ACC meeting, and I did not get to all the studies. There are still some noteworthy topics to sort out from ACC. One is renal denervation. For instance, the spiral hypertension on med study, this has been published in The Lancet, and I'm doing a journal club on this next week, and I will let you more on this study coming soon. Renal denervation is making a comeback. There are many studies in this space. They use different study designs, different devices, versus the old Simplicity 3 days. This is a super complicated topic, and I just need more time. Okay, as ACC was ongoing, the European Heart Rhythm Association meeting was happening in Copenhagen. Now, it's unfortunate the two meetings overlapped. I hope that changes in the future. At European Heart Rhythm Association, a number of studies address 3 white-hot topics in electrophysiology. Now, I realize that EP is a subspecialty, so I'm going to attempt to keep this interesting for a broad audience. The first topic is a new ablation energy source called PFA, Pulsed Field Ablation. PFA works via a process called electroporation. Now, this is a technique that involves applying electrical current to the heart, which then disrupts current flow across the cardiac cell membrane. It results in pore formation and cell death. Now, recall that the very first ablation was DC shock to the AV node. PFA is sort of a super-controlled form of DC shocks, and patients have to be under anesthesia to have PFA. The main upside of PFA is its cardioselectivity. It purportedly does not harm the adjacent phrenic nerve or esophagus structures. It's also quite fast. There is massive excitement in the EP community about this new technique. At European Heart Rhythm, Dr. Vivek Reddy presented results of a large European experience with a first-generation PFA system. Now, PFA earned CE mark about 12 months ago in Europe, and Reddy had a survey from 24 European centers on about 1,700 patients. The study was called Manifest PF. Now, the results here were mixed. Patients in this retrospective observational survey were typical in an ablation cohort. They were about 62 years old, mean CHA2DS2-VASc score 2, normal ejection fractions. All patients had only one transeptal puncture. The mean procedure time was 65 minutes. Mean fluoroscopy time was about 13 minutes, and 16% of patients were discharged the same day. I want to stop there and just pause there on that and say that this is not much different than my RF ablation procedures, and it's probably longer than my colleagues' cryoballoon procedures. Okay, the second result, the success rate using PFA was similar to the standard 99.9% of all PVs isolated. In the survey, Reddy told us there were no esophageal fistulas or PV stenosis. However, there was one transient phrenic nerve injury and coronary vasospasm. The phrenic nerve injury was very short-lived, but again, PFA is supposed to be cardiospecific, so you wonder how that happened. There was also a 1% rate of pericardial tamponade, 17 of 1,700. 4 of these required surgery. There were 7 strokes, 1 fatal. The incidence of strokes, 0.4%. There were 56 vascular complications, and the majority were hematomas. The rate total is 3%. Now, Reddy presented another slide comparing major versus minor adverse effects, and the major adverse event rate was 1.6%, minor was 3.9%. Another finding of note was that 114 patients, so a small subset, had MR brain imaging post-procedure, and the rate of, quote, positive MRs or silent cerebral ischemic events was, get this, 17.5%. Well, I worry a lot about these ischemic spots on MRs after the procedure because PFA is known to create significant bubble formation in the LA. A British EP doc, David Tomlinson, and I wrote an editorial in JACC on an early PFA study, and one of our main points was it was really missing data on post-procedure brain scans. I'll link to this editorial in the show notes. Now, this type of study is not an RCT, but it is important data. Observational registry-like data tells us what we are actually doing in the real world. And Europe has a head start with PFA due to the lower regulatory standard there. Now, good on the investigators for reporting this data. In some, though, PFA has great potential. Early studies do look promising. But as Dr. Reddy pointed out, a painfully small number of patients have been studied with this technique. And this early data from Europe shows procedure time, X-ray times, complication rates not much different from contemporary AF ablation. We don't have any efficacy data. We have little randomized data. And to be honest, I'm glad the U.S. regulators have not approved this energy source. It may be great. It's likely going to be great, but we have far too little data to embrace it yet. All right, another way to ablate left atrial tissue. Here's another hot topic in my field. It's called high power, short duration. This is another way to ablate the left atrium. You use high power, short duration RF energy burns. And the core issue with AF ablation is doing enough ablation to durably isolate pulmonary veins, but not so much to perforate the heart or do damage to the esophagus phrenic nerves. It's like the Goldilocks amount of RF energy. Now, the concept of high power, short duration versus standard lower power, longer duration hinges a bit on physics. Heating tissue from a catheter tip results in immediate resistive heating and then later conductive heating. Now, low power, longer burns leads to more resistive heating, which can go deeper, and high power, short duration results in more conductive heating, which leads to less depth but possibly greater lesion size. So the three goals of using a high-power, short-duration lesion is A, safety. Less depth of the lesions may spare the esophagus because the esophagus sits right behind the left atrium. B, efficacy, as larger lesions may make for durable ablation lines. And C, speed, as short burns make for faster procedure times than longer lesions. And there have been many studies comparing high-power short duration to standard RF, but these are often small studies, often single-center studies. At the European Heart Rhythm Association, Professor Jose Marino presented results of the PowerFast 3 trial conducted in Spain. This had 267 patients with atrial fib for less than a year, 12 centers in Spain. Patients were randomized to low power, longer duration, and they received about 25 to 40 watts, which is sort of standard, and ablation was continued according to the lesion size and ablation indices. The high power short duration patients received 70 watts for 9 to 10 seconds. Now, endpoints here were efficacy and safety. Safety included, get this, acute esophageal injuries noted on post-procedure endoscopy. That's cool. All patients got EGD after the ablation, so we get to see the esophagus. For efficacy, there were some interesting findings. First pass PV isolation, that is, getting isolation on your first attempt to make a circle around the pulmonary veins, was actually better in the standard ablation arm. First pass isolation is thought to correlate with better durability of PV isolation. Now, Professor Marino went quickly over that slide, but it's surprising that despite all this hype, standard ablation did better at first pass isolation than high power short duration. And also, for acute PV reconnections, there was no significant differences, but there were numerically more reconnections with high power short duration. Again, this is surprising given the use of 70 watts in the high power arm. American RF generators only go to 50 watts. Now, they also presented procedure times, and they were not significantly different. No difference. For safety, esophageal lesions, there was also no difference. 6.5% versus 7.5% of patients had some procedural esophageal lesions noted on endoscopy. Of course, this is good and bad news. On the one hand, you'd like the high power short duration to be lower, but on the other hand, at least it wasn't worse. Now, for total complications such as pericardial effusion and bleeding and stroke, there were no significant differences, but there were strong trends against high power short duration. 1 effusion versus 4 in the standard versus high power arm, 0 strokes in the standard, 3 strokes in the high power arm. Professor Marino concluded that the techniques were statistically similar, but he did note the trends against high power short duration. Now, this trial is not yet published, but it is sobering data. I've not yet adopted high power short duration because it scares me, and this data sort of supports that cautious approach. The trial found less acute efficacy and trends for less safety. I've adopted a very cautious approach when I'm ablating on the posterior wall of the left atrium. I've ablated atrial fib for 16 years now, and I've been lucky enough to avoid a catastrophic atrial esophageal fistula. I think it's reassuring that PowerFast 3 did not find higher rates of esophageal lesions, but I think we need a lot more data before we adopt this more aggressive ablation strategy, and I want to congratulate the investigators, and I look forward to reading this paper. Next topic is left bundle branch area pacing. Now, because I grew up in the heyday of ablation, I used to feel like pacing was boring. Now, though, with age, I've come to love the purity of pacing. Patients are sick or they're dying, and pacers make them well. It's one of medicine's most beautiful therapies. But even better, we now have conduction system pacing. First, there was His bundle pacing. Now there is left bundle pacing. Both of these can be lumped into the category of, quote, conduction system pacing. And the promise is that if you pace the rapidly conducting His-Purkinje system, you avoid that muscle-to-muscle slow conduction, those ugly, wide-paced QRS complexes, and the dysynchronous conduction of standard RV pacing. You might wonder, hey, Mandrola, the left bundle is on the left side of the septum. How do you get a pacing lead there from the RV? And I actually wondered that too. And this may sound a bit peculiar, but the way you do it is to place the lead on the mid-septum with a sheath, and then you screw the lead like it's a screwdriver through the septum a few millimeters until the tip of the pacing electrode gets close, but not through the septum, close to the left side of the septum, and the left bundle sits endocardially. Now, the tip of the lead captures the left bundle or the area of the left bundle, and the conduction spreads down the left bundle first and then results in rapid left ventricular activation and a right bundle branch morphology QRS. Recall that in right bundle branch block, the left ventricular activation is not delayed. Also recall that the left bundle branch arborizes very quickly into fascicles after the proximal left bundle. So when we do this pacing, we're often capturing fascicles of the left bundle when on the left side of the septum. At European Heart Rhythm, one of the most active conduction system pacing experts, Dr. Marek Drazbowski, presented results from the MILO study. This was a massive European effort from 14 centers and 2,500 patients. 27% of these patients were implanted for heart failure. 22% of them had left bundle branch block. Now, some of the more interesting findings from this observational real-world data on left bundle pacing was that first, there's a big learning curve. The plateau is reached after 150 cases. Success rates for bradycardia were 92%, but success rates for use as in a CRT device was 77%. The pacing parameters with left bundle branch pacing is far better than His bundle pacing, and this study shows it. I mean, thresholds are below a volt, R waves are huge, and the paced QRSs are fairly narrow. Complications, the authors tell us about septal perforation. This was 3.7%. So the idea is that the lead goes through the septum into the LV, but then you pull it back and you reposition it. Of course, this is not the same as cardiac perforation when you perforate an RV free wall and there's bleeding into the pericardium. Septal perforation during left bundle branch pacing happens not infrequently, and you pull back the lead and reposition the lead. The lead is extremely narrow or low profile. Then there are the normal complications seen with other pacemakers, but there are some rare left bundle specific pacing injuries, such as rare episodes of coronary artery injury. The total complications were 8%, and this is similar to standard pacing. But many of these included that transient septal perforation, which is not known to be a severe complication. So my comments briefly. I've moved to almost 100% left bundle branch area pacing when doing a standard Brady pacemaker. The learning curve was substantial. However, once you get it, it becomes much easier. It's 10 times easier than His bundle pacing. What I like about this are a couple things. The pacing parameters are amazing. You're also working in the septum, so perforation leading to tamponade is less likely. You get these amazingly narrow QRSs. You avoid the dyssynchrony of RV pacing. And also, the lead that's used for this has been around for years and years and years and has an excellent track record, and I love that. Yet I agree that we need more data, especially when using this for correction of left bundle and CRT, and there are ongoing studies. Yet if you don't do this procedure, if you don't practice it, you can't really use it as a bailout for CRT when there isn't a vein. The potential downsides also extend beyond just this Milos data. It includes the long-term performance of a lead with a hinge point in the septum. And finally, I have to admit the bias of beauty. I went into cardiology largely based on the magnificence of the ECG. The ECG of left bundle branch capture is truly a thing of beauty. I've had multiple calls from nurses on the floor who are concerned that they can't tell that the heart is paced, and it makes me tingle with delight because that means the paced QRS is so natural looking, like it was when we came out of our moms. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please tell a friend, give us a rating, write us a little review. These sorts of things help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.